All right, here's a topic that nobody likes to talk about is complications. So, but a very important topic. We're going to be doing this work, and as we all know, complications definitely can happen, and it's important to recognize those, and more importantly, to talk about you know, how we can learn from those and prevent them for other cases. So yeah, you know, this is going back to a slide I showed yesterday. We all know 2015, very exciting year for stroke and thrombectomy, establishing it as a standard of care, you know, a very powerful treatment effect. But if you look on the safety side, I mean, that's a kind of a win-win, is that it's also, thankfully, a very safe procedure, as you know. I tell operators, you know, aneurysm case, an unruptured aneurysm patient comes in, it's kind of all big-time risk on our end. In other words, this person is walking in, and there's only things can go wrong, so to speak. In a stroke case, it's kind of the other way around. This person has the complication. They have a blocked vessel that's occluded. Their brain is dying. So it's okay. You know, yeah, that's right. So so very safe. You know, if you look at the symptomatic intracranial hemorrhage rate, low. The big bad bleeds that we really worry about, these parenchymal hematomas type 2, again, very low. Mortality rate is low, so that's good. But having said that, we know that nothing worthwhile is ever without complications. So even though it's relatively safe, it's not 100% safe, and nothing that is worthwhile is ever easy. So it's, you know, what kind of problems can we encounter? Well, it's fairly straightforward, obviously. When we look at causes of complications, you know, a treater is involved in the case. So is it an operator or human error problem that created a complication? There's obviously the patient. So these patients can have many comorbidities, as we know. They can anesthesia is looking after this patient. Is there something that goes wrong with anesthesia? We have a nursing team, angio team. Does, you know, their interaction with the patient, or you know, we're working with medical devices. Is there a device problem? So I'm going to go flashback. This is me many years ago, right out of med school. I did a little time in the Canadian military, and I was a flight surgeon. And what I learned in that experience, one of the jobs in that world was that you unfortunately had to investigate airplane crashes if they occurred. And that was not very pleasant work, obviously, but you know, the whole endeavor of that was basically to understand what happened, but more importantly to say, okay, is this something that we can train pilots that, you know, not to make this mistake again, and you know, what can we learn from this experience? This is me out on a crash site for up in northern Canada. We're wearing these hazmat suits because those planes are made out of composite fibers, so it's something you can't be exposed to or breathe in. And yeah, it's a bit of a grisly task. You're going through and collecting all this debris. But again, the effort is to understand what happened and to, again, train so that it doesn't happen again. So if you think of it from a aircraft, you know, investigation point of view, you know, for us, the device is like the plane. You know, did the plane mess up, or in our case, did the device mess up? And you know, it's usually fairly, you know, uncommon for it to be a device problem. In our cases, that usually the devices, obviously, there's a lot of quality assurance that occurs, and so, but it's not impossible. So we have to ask: was it a failure of the device? Or, you know, did we use the device improperly? So it's important to, again, all these devices have their indication for use, the IFU, and that, you know, they've been tested to those standards, and it's important to not take them for a test ride, so to speak, and push the limits on what the safe way to use a device is. From the operator point of view, you know, again, in aircraft crashes, and I think it's very similar in our world, is that human error, operator error, is probably the #1 cause of what happens in complications. So we can ask ourselves, go down a list, was it a training issue? Were we basically kind of ill-equipped or ill-prepared to handle the case or the complexity of the case? Did we exercise poor judgment, a poor treatment plan? You know, we all are prone to being tired at 2 in the morning, coming into doing a case. Distractions, we have many distractions that are going on in our world. Were we in a hurry or rushing? So these are all types of things that, again, we have to ask ourselves. And one of the big things I think in our world is this, many people quote this, is that, you know, don't let perfect be the enemy of good. When we're in the middle of a case, we tend to want to, oh wait, there's that one little clot out in the M4, maybe I need to go after that. It's important to, you know, again, if the main job is done, it's important to stop there and not try to make, you know, the picture perfect. So yeah, again, we're not treating a picture. That's an important thing to remember. We're treating the patient. And so it's, you know, obviously when patient's asleep, all we're looking at is our angio images. Sometimes it's tempting to try to make that picture look perfect, but it's also knowing when to quit. So, you know, looking a little bit at the good, the bad, and the ugly things that can happen. There's been papers that have, you know, shared their experience. This is from our colleagues in Switzerland. They looked at a 4-year period of their cases, specifically looking at complications. And they kind of broke them up into the stroke patients that were coming in within 6 hours of symptom onset versus what we would call our late treatment window, those patients beyond 6 hours, 6 to 24. And if a complication occurred in those patient populations, you know, did it make a difference? And so they had 113 had at least one procedural complications out of the 695 patients. And so overall procedural complication rates were similar in these two groups. If you presented in that early time, your complication rate was 16.2%, and almost identical complication rate for the late presenters. This complication rate is higher, again, I think, you know, sharing a real-world experience than what other studies, the ESCAPE study and Diffuse and Dawn, all had complication rates kind of in this range. But I believe this complication rate in the real-world experience. What are the broad categories in the study that the complications you know, occurred in? It was really access issues, bleeding at the arteriotomy site. As we know, we can do a great case, and a big-time retroperitoneal hematoma can turn that into a catastrophe. So access problems, and then obviously the cerebrovascular complications that can happen. So if you break it down, you know, in a little more detail, the access complications are significant, you know, hematoma or hemorrhage at the puncture site, pseudoaneurysms, dissections, occlusions, and other access issues. If you look at the cerebrovascular complications that can happen, as Dr. Schaff was saying, we're trying to protect against, you know, taking a clot and putting it into a territory that, you know, wasn't affected initially, so embolizing a new territory. Dissection, spasm, perforation, subarachnoid hemorrhage, and so these are all the, as we know, the things that can occur. And what they found basically was that if you had a complication, particularly with those patients that are in that late window, the 6 to 24-hour presentation, that the complication led to a significantly worse outcome, basically. Your favorable short-term outcome was reduced. And so also these patients with complications in that period, even if you got a great recanalization, they tended to do poorly. So, you know, the main takeaway from this paper was really, you know, we want to avoid complications, but particularly if patients are in this later, you know, time from presentation, a complication can really be devastating. So it's important to prevent, monitor for, and rapidly manage procedural complications in that group. I just show this picture. This was a gentleman that got transferred in, an elderly gentleman. He'd had TNK, which is working very well as a lytic, but as we know, sometimes, so he'd had a cardiac cath that was the cause of his stroke. And then they recognized he had a stroke, gave him TNK, and at his arteriotomy site from the cardiac cath, when he came to us, he had a very, very large hematoma at the access site. Other things that we talk about, vasospasm is something, catheter-induced spasm, dissections, and then, of course, we can move on to bigger and more worrisome things such as perforations. For vasospasm and dissection, I often, in a training platform like this, say it's better to just try to avoid these. So in other words, if you can, we take catheters, very distal now, and large catheters very distal, but it's, better to try to take something that was designed to do that. So we have a stiff long access sheath. It's not critical that we try to get that particular catheter all the way to the, maybe Petrus ICA. It's better to, the stiffer catheters, lay them up proximally, take a catheter that was designed to be more flexible, through tortuous anatomy. So avoidance is key. If you look at, in this case, the path to get intracranial is kind of twisty-turny. Sometimes we have, these kind of paths, a lot of disease and FMD in this segment. So, take a look at what you're dealing with, and even, doesn't matter whether we're going to be, like I said, a long access sheath person, a BGC person. You have to ask yourself, is it worth it, to take that catheter way, way distal, or where do I need to be to get the job done? Here's a M1 occlusion. Again, some twists and turns to get there. I'll show that, nowadays there's some very nice delivery tools. Dr. Schaff showed, kind of one of the ones that Capel's coming out with. This case shows a Route 92 catheter with the tensing. And so, yeah, you don't have to get this stiffer, long access sheath through all this anatomy if you, basically have, shoulder reduction tools that can do these S-turns. We're now a little bit further north in this case. And, once you get some purchase, so to speak, you can, bring up your longer access platform. But I'm not going to take it around these turns, straighten this vessel all out, just because, again, we can almost expect that this vessel's probably not going to like that. It's going to be catheter-induced spasm at a minimum. Worse, maybe a dissection. So, think to yourself, how far north do I really need to take the, the catheters that are stiffer, if you like. So we can see, with that kind of support and these newer technologies, we can fairly easily, deliver a catheter through a lot of bends, but use the flexible technology that's been designed to do these paths. And then, we've got the M1 open. Here's just another way of doing it. Like, if you need to get better purchase, I'm doing a combined approach, so I have a stent retriever deployed, I have an aspiration catheter, and this aspiration catheter is, now filling most of the lumen of the long access sheath. So it's a nice rail, so to speak, to deliver that. If you need to bring this around, this was like a 360 loop, and I needed a little more support. So at that stage, when you have the shoulder reduced in that catheter, that's when you can attempt to take it a little bit, further distal if you need. We all do work in the posterior circulation. As Dr. Schaff quoted, I have a healthy respect for the basilar and the verts, and so the path to get there, as we know, can be, all these bends, acute angles, stenoses. So once again, I tend to lay up proximal with the stiffer catheters and just take our working catheters, so to speak, the aspiration catheters, et cetera, that are flexible to navigate these, and straighten these bends. And I often don't take something like a, 8 French sheath or anything, through a vert like this. Again, you want to be careful. This is, now just going up, so you can fairly easily navigate even difficult anatomy. The thing you want to avoid is at the end of your case, pulling your catheter back and seeing a nasty dissection like this. That can obviously be a bit of a showstopper and a very difficult problem to deal with, especially if this is the dominant vert or the only vert. So again, avoid dissections. Last sort of topic, and this is the one that gives us the most angst, is that we did a pass in this case, so we've done one pull, and we see something that looks a little weird here. Run it out a little further in the run, and you can see there's just a gross perforation here, and arteries bleeding. So first step is really to check your own pulse. Don't panic. Okay, so don't push the panic button. But this is truly, as we all know, this is our major emergency. This patient is not going to do well unless we do something quickly. So here's taking up a balloon, just securing and basically tamponading the bleeding. Went on to try a few cycles of occlusion with the balloon, see if this will sort of seal over, as we often do in an aneurysm case. But sometimes it doesn't, so it's still bleeding, and went ahead, coiled off the M1. But as we know, these patients, this is a very serious complication. The CT after looks horrible, and a lot of times these cases, the patient will not survive, as was the case here. So other thing we can kind of do and create a problem with injuring a vessel, and this one's a little bit better outcome for sure, is if we create a CC fistula. If we create a CC fistula, again, don't panic. I think you guys are the world experts in dealing with CC fistulas. So it's starting with, okay, we got the stroke case done, but now we have to fix this fistula. And so, it's the same. I think oftentimes people treat it in the same setting, and I think, you can go ahead and do your balloon occlusion if you can, put some balloons to tamponade this, go across the tear in the vessel, pack it with coils, but yeah, just treat it like you would a CC fistula. And again, the literature gives us some help and guidance. This is a paper that I just put in here for your, that you can look up at your leisure. But for dealing with vessel perforations during thrombectomy and some of the technical details and clinical outcomes. So, in summary, when you think about a complication, it can be very painful for us to force ourselves to go through this exercise, but don't come in with essentially, hey, I'm gonna, not really look at all the different things that may have happened. So no preconceived notions, really let just the facts explain, what happened. There's really no single cause for a complication. It's usually many factors that lead up to what happened. And no two complications are exactly alike. They often have similar problems, but it's important to really take away from a training point of view, what particularly happened in this case. So this was Einstein's quote, an intellectual solves a problem, a genius avoids it. So I think it's important to try to avoid the problems. So I'll stop there and answer any questions. So thank you. Come on.